Hello, everyone. Welcome to First Aid AMC Clinical. We are waiting a little bit to see that if others are joining. And this is actually a trial sessions for those of you who are preparing for AMC Clinical. Okay, now, for those of you who don't know me, I am Dr. Arshan Ahmed, and I will be the coordinator for your next 5 months AMC Clinical exam preparation. To give you a little bit of idea about me, I have been working in Australia for quite a few years now. I have all the experience about Australian health system. I've worked in both GP system and hospital system. It's not only just me who will be your mentor for this course. There will be also a few other doctors who is also working in Australian health system, who is going to help you to prepare for your AMC clinical preparation. Tonight, we are going to give you an idea how this course is going to be. And all of you must know that our new 5 months clinical course is going to start from 29th of April, and 2 weeks free session that we provide for everyone, even if you don't join the course, that's going to start from 3rd of May. Our class is always exactly same like this. Doesn't mean that for trial session, it's a huge thing that we are doing. It's always the same thing for us. That's why we always allow you to join our 2-week session so that you get an idea about our teaching method. You get to know our different mentors so that we just don't take one trial sessions and then you join the course and you feel that it's not satisfactory. So we give you an idea about the full course, how it's gonna happen in those 2-week session. So every one of you is welcome to join that session. We will provide you all the class schedules for those 2 weeks, and you join the class. If you feel that this is what you are looking for, then you join. And I'm also very glad to see that many of you has already joined our course, even without trial class. And also you have started your preparation because we have started to provide you the link into your portal. You have been approved to our software, and you have been seeing the videos and the lecture notes by yourself for now. And I'm really glad that you guys are doing that. It means that when we start the course in full rhythm, you will be well aware of few questions, the cages and everything. So feel free to join the course if you think that this is the course that you actually want to join. And then we can approve you in our portal and you can start your preparation. At least get to know the cages, see some of our videos of previous batch lectures. So that's not a bad idea, I always say. AMC clinical exam is one of the hardest exams that you might appear in your whole life. And that's why the passing rate in this clinical exam is really not that much. Now, if you think in other way, passing AMC MCQ is not that much difficult. But you can get a job by passing AMC MCQ and having English test. But if someone is saying that you don't need to pass clinical exam and you can just do your job in Australia, they're actually showing you a wrong path. And if you follow that kind of people, you're just falling into a very bad trap. Because AMC clinical exam is very important, and most of you will need to go through the AMC clinical exam. Only alternative for clinical exam is WBA pathway, which is your clinical based experience, which most of the Australian hospital doesn't provide. And also you might not be able to get into that. If you are lucky, then yes, WBA is another alternative for clinical. But even if you get a job in Australia by passing AMC, MCQ and English, For your general registration, you need to have your clinical exam. So APRA usually gives you 1 year time to pass the clinical exam after you start your hospital rotation. Sometimes you can increase that amount of time, but yes, for general registration, you will need to pass this clinical exam in one way or other. So there is no bypass that you can think about. And if any people, anyone who know, they just say that, well, don't think about clinical exam, just do your MCQ and you are good. It's not right. I will take a session with you about the whole Australian system and how to get the registrations from limited registration to general registration. That class will come in few weeks' time. You will get a good idea about it so that you get some information rather than getting into those people's trap. Maybe they don't even know about it. So that's why I always say that learn from people who have experience in this field. Don't listen to people who are showing you the wrong or alternative ways. Coming back to clinical exam. Clinical exam is hard, but it doesn't mean that you can't pass clinical exam. It's not an impossible exam to pass. Any exam which provides you the full registration to do a job in any country, it's going to be hard. That's how it should be. But obviously, AMC Clinical, they have made it a little bit more harder than other kind of examination. After USMLE, AMC Clinical exam is the next hardest exam that you can go for. So obviously it is hard, but with appropriate preparation and guideline, it's not impossible at all. Because if you are on our Facebook group, which is the First Aid AMC Clinical, you must have noticed that every month, almost 8 to 10 candidates, and most of them are first-time attempt. They're passing their clinical exam with just this 5 months clinical course, nothing else. There is no need of any books, any notes, nothing. Just this clinical course they're doing, and they're passing the exam. And most of them, I say, that they are first attempt, which was impossible, like nearly impossible few years ago when there was not a good preparatory guideline in Australia. So we are proud to say that this is one of the highest passing, especially highest passing rate for AMC clinical exam from our course. And that has been like this for the last 3 to 4 years. Almost every month, we have the highest number of passed candidates. And the reason behind is that how we actually make your preparation concise and how well you get prepared with us, that shows the standard of the course. And I obviously ask you to go through the course details, listen to our lectures, at least this trial session and the next 2-week session, and get an idea. I'm sure that you will feel interested. Now moving on to our tonight's sessions, which is psychiatry review session. Psychiatry is one of the most important topic for your clinical preparation. It's not about just psychiatry. It also gives you a good idea about your approach. Clinical exam is not about how well you know about a case, how knowledgeable you are. If you are a specialist in your country, doesn't matter. Most of the specialists fail this exam. The reason behind is that AMC clinical exam is designed for junior doctors, and it has its own guideline to follow. If you don't work in Australia, you don't know that. Someone who is working here needs to show you those guidelines, needs to show you the approach of each of these cases that can appear in your exam. And that's where we come. So let me give you an idea about the clinical exam, and then we move on to the psychiatry review session. So tonight we are not going to go through a huge amount of cases. It's about get to know these classes, get to know about clinical exam. Many of you already know about clinical, I hope, but many of you are beginners who just passed your MCQ exam and you don't know what it is. For those of you who just passed your MCQ exam, let me just give you an idea about this clinical exam, how you should do the preparation. So first of all, your clinical exam is like an OSCE exam that you have done in your medical university or college. In this case, first of all, you pass your MCQ exam, you get eligible for clinical. You don't need to pass English test to appear the clinical exam. Even without English, you can appear it. English is needed for your job application, not for clinical. Once you want to go for clinical exam, let's say you are appearing the clinical exam after a few months. The clinical exam, there are two versions of it. One is an online version and another is face-to-face version. During the COVID era, online was the most preferred one and most available one. But now, face-to-face is the most available one and most of you will go for face-to-face. There is hardly a few slots available for online exam nowadays. And there is a high chance that over this year, online exam will disappear. For face-to-face exam, the exam happens only in one center in Australia, that's in Melbourne, NTC. So when you are registered for clinical exam, in the morning or afternoon, especially in the morning, you go to the NTC in Melbourne Center. In the NTC Melbourne Center, in the first floor, there will be some receptionist or cadets who is going to escort you through a lift to the AMC Center. Once you go to the AMC Center, you will be given a ID card that you are supposed to hang on your neck. They will give you a locker so that you can put your stuffs in there. The only thing you will be allowed to take into the exam is your stethoscope and that ID card hanging around your neck. Nothing else. You can't take your watch. You can't take anything else. Once you go in, there will be an orientation about how this clinical exam is going to happen. Someone will show you a video about it. After that, each of you will start your clinical exam someone of you will start from station 1, someone will start from station 16, like this. Now coming to the stations, there are 16 stations for this clinical exam. With 16 stations, there are 4 stations which are rest stations. Among these 16 stations, 14 stations is a scored station. That means you are going to get a score on this. And 2 stations will be pilot cages, but you don't know which one is pilot. Out of this 14 scored station, if you pass 10 out of 14, you pass the clinical exam. Okay, now let's say unfortunately, if you don't get 10, let's say 9 by 14, you fail the exam. There is no, you can't take, previously there was few other opportunity that you could just take not the 16, just 8 stations if you fail the exam. But that option is no longer available. If you fail, you will retake the full exam again. All right. So our goal is to pass these 10 stations out of 14 stations, and you pass the exam. That will be our aim for this. The 4 stations over here that you see, there's a rest station. After every 4 stations, you get a rest station, and that's how you rotate around each of these. Now you might be thinking, what are these stations? Stations are cages. So you have 16 cages in the exam, and each of these cages will happen in single room. So there are 16 rooms for 16 stations. Outside of that room, there will be a monitor. And on the monitor, you get the question. Let's say your first case is station 1. So station 1 will be on the room number 1 monitor. You get 2 minutes in the outside of the room to read that case, to read the task of that case, and to think about the case, that what you are going to ask to the patient, what investigation you will do, how you are going to manage this case. So you think in that 2-minute time. After 2 minutes, there will be a bell. You knock the room, an examiner will open the room. Once you enter into the room, your 8 minutes starts, which means for each of the case, you get 10 minutes, 2 minutes outside, 8 minutes inside. And your score will depend on what you do in that 8 minutes. All right. Once examiner gets to see you, examiner will say that, can I check your ID? So then you show your ID, examiner confirm you are the person who are supposed to be here. And then examiner say that this is your patient. So there will be a role player inside the room, and examiner will introduce you to the role player. And examiner will give the name of the role player. Your job is to remember that name, because if you always say John, Sarah, this kind of thing, but you forget about the patient name, that doesn't look good. So remember the name of the patient. Once examiner introduce you to the role player, you go in. So you thank the examiner. So thank you, examiner. Examiner asks you, do you have any questions? You say no. Then you go in. If there is a table, you sit on the table, and then you start your case. So this is how it's going to happen. After 8 minutes is done, there will be another bell. And it means that your station is over. You are supposed to leave that room and go to the next room. Same, this is the way you are going to rotate 16 stations. You are not allowed to write anything in the 2 minutes outside, but you can write anything in the 8 minutes inside. There will be a pen and paper on the table, so you can write. Excuse me. Okay, so did you guys get an idea how the clinical exam is going to happen? Now, I know that you have a lot of questions in your mind about the course, about the classes. We are going to answer each of those questions after end of tonight's session. So ask any questions. I will allow you to ask even by unmuting yourself, and then I can answer you. But I always keep the class time totally muted. You can always write in the chat box. For those of you who are in Facebook, we don't take classes on Facebook just because you might have difficulty to join the Zoom. We have allowed it this time, but always try to join the Zoom sessions like this. You can write on the Facebook comment section, and I will have a look. And obviously, for those of you who are in Zoom, any question, feel free to write on the chat box. I always keep it open on my side. Okay. About the online examination, online exam is a little bit different than the face-to-face exam. How so? Because obviously you are not going as a person in the exam. So online examination is a little bit different. Nowadays, online exam is not very commonly you will be able to get into, because they are not providing that much of a date for online exam. But if you are lucky, then it's really good. There is no one way or more to say that which one is easier. Online exam is easier for those of you who have very good fluency in English, who are very confident when you talk. For you, online exam is a good idea. But if you are struggling with your fluency of English, or you're not very confident to talk a lot, then face-to-face is a good idea. Because face-to-face, obviously you need to talk, but online exam is all about talking, because they are not seeing you. It's all about how you present yourself, how well you are talking. That matters a lot in online exam. So for online exam, that happens in a Zoom session like this. There are usually 32 students in a Zoom session, and each of you will be divided into particular breakout room. So there will be separate rooms where you will be appearing your exam. In each of the room, you'll be given one case. There will be a role player on the video with you. There will be two other person. One will be who is just going to help you if you have any kind of issue in your internet, any kind of issue in the exam. So they're just going to moderate your exam, but they are not usually anyone related to the health profession. And then there will be an examiner on your room, but examiner is not going to show his or her face. So examiner will be there, but you can't see the examiner, and you can't ask anything from the examiner in online exam. Okay? Everything else is same. So your task is same, how you present the case, everything is same. It's just, this is the difference, that in online exam, you get to talk to the role player only, no one else. Once your exam is done, you will be sent to another room. In that way, you will be routed 16 station. You might have a question in your head that, do I need to remember the full case? Because I just get to see those pages in the outside in 2 minutes. Is there any case written in the inside room? Yes, there will be a paper on the exam table where the case will be written as well. But sometimes we see that sometimes it is not there. So I always say that don't take that risk. Remember the task, remember the case. You already know that what is the case all about, like patient presenting to you for a headache. So you know that it's a headache case. Only thing that you are supposed to remember is the task. The task means history, physical examination, management. Whatever is the task, try to remember that, because it helps. Otherwise, sometimes even it is written on your paper inside, you can forget. You can waste time, and you can just look on the paper time to time. It doesn't look good in the exam. All right, so a lot of talking. I'm sorry if I am boring you, but these are the important things that you should remember. You should understand how this exam is going to happen. Only when you understand it, you can take a good preparation. Throughout the course, we will give you ideas how to improve yourself, how to do face-to-face exam, what you are supposed to do in online exam. There is a lot to learn. It's not just the end of the orientation. There will be a full orientation once you start the course after these 2 weeks, where we are going to show you each and everything that you need for both of those exams. But let's start our tonight's session. Okay? We are going to do a very important topic, which is what we call as psychosocial history in psychiatry. If you heard about first aid AMC clinical, you must have heard that we make sure that your preparation is very short. We don't give you 300 cases and ask you to remember 300 cases. We give you few small cases and we use that simple format for almost every cases. Like this psychiatry, this psychosocial history, you will be using in every psychiatry cases. That means with single format, that will help to cover at least 100 cases. So that's how we are supposed to make your preparation very formatted and concise. That way, you don't need to remember different cases by different format. You use one single format, you just remember the management of each of the cases. Management is obviously different, so you need to remember just the management. History, physical exam, we use same format, and if you just learn that format, you are good for the exam. So starting with a psychosocial history, if you don't understand at any point, please make sure you ask me or write it in the chat box. And anything you have written on the chat box, if I am not answering right now, just wait until the end of the class. I will answer each and everything that you have written. Okay? So for psychosocial history, when you get a psychiatric case in the exam, the first thing that you are supposed to ensure that you give enough confidentiality to the patient. Patient need to understand that this is a safe environment and they can talk anything that's going on in their head. Psychiatry is a very tricky thing because it's about your thought. It's about some silly thing that's going on in your head. And if you don't feel safe to talk about it to a person who you don't know, you will never ever open up. So you as a doctor are supposed to make that environment for that patient so that they feel safe to talk to you. And the first thing that you ensure is that you give the confidentiality statement. So any psychiatric case, if you forget to give confidentiality, they would not open up, they would not give you information that you need for that case. And the exam is designed in that way. And the role player, they are directed that if you don't get confidentiality from your doctor, don't give information that candidate needs. So that's a permissible thing role player already can do if you don't give the confidentiality. So how to give confidentiality in a psychiatric case? There are two ways. One is conventional and boring way, and the other one is an alternative approach that I always use, and I always ask our candidate to use if they can. The conventional approach will be used by almost anyone in the exam. And then you become just a part of a group who are using the same thing. An examiner knows that you just read the Karen notes or maybe a note. An examiner understands just by listening to you. But I say always that use your own sentence in the exam, and that will make you as a different candidate than others. This is not a competition or this is not a competitive exam. Anyone can pass or fail. But as a human being, if you sound a little bit different from others, examiner will like that. And most of the time, this kind of candidate pass the exam. So we don't ask you to use anything which is very conventional, which everyone uses. We give you something different so that you can be different in the exam. So when you get a confidentiality, first of all, conventional approach is like that. Let's say your patient presented to you with very sad mood, suicidal thoughts, and having loss of interest for the last few months. How you are going to give confidentiality to that patient? Conventional approach is that we say that, John, this is Dr. X. I'm one of the doctor in this clinic. I'm very sorry to know about what you're going through. John, I would like to help you in this situation, and I would like to ask you a few questions regarding that. Let me assure you, whatever we talk today is going to be between you and me unless it is harmful to you or others. So this is a very conventional or easy way to give confidentiality. But we use alternative approach. Always in psychiatry, your approach is all that matters. In exam, one of the marking that you get is just about your approach. We will talk about the marking in a little bit at the end, just remind me. So approach has its own marking in the exam. So your approach should be really, really good to pass psychiatry. In other cases, medicine, surgery, approach can be a little bit different, but psychiatry approach needs to be polite, needs to be very calm and confident. So you greet politely with the patient and you can say that, John, I can see that you are really sad. I'm really sorry for that. I want you to know that we are here to help you. You can tell me what's making you really stressed. Sometimes, John, things can happen in our life that we don't have any control over. And it's not your fault. But I want you to know that with appropriate care and guidance, this can be managed and you don't need to feel this way. I'm here until you are ready to talk. And I want you to know that whatever we are going to discuss today, it is between you and me, unless it is harmful to you or others. So see that what is the difference between the conventional approach and the alternative approach? You are making a safe environment for the patient to talk. If you use your empathic voice to a patient, there is no patient in the exam who is not going to answer your question. We always find out that candidates asking that role player does not talk to me. Role player is very abusive. Role player did not give me the information. It's not the role player who is at fault. It's your fault that you are not able to make a safe environment for the patient to talk to you. We forget about how well our communication should be with a patient. In your country, you might be in a hurry to talk to a patient. You don't bother about these kind of things. But in Australian exam, this is the most important thing. It doesn't mean that you finish your task, doesn't mean you give a lot of information about the condition. That's not going to make you pass the exam. The only thing that's going to make you pass the exam is how well is your communication. Communication doesn't mean if you are very fluent in English, doesn't mean you have a Australian or England accent. If you can show that you are empathic to a patient, and if they can understand you, doesn't mean that you can have any kind of accent. Asian has a different accent than others, and the role players are well aware of that. That's totally fine. There is nothing wrong with that. As long as they can understand you, what you're talking, you're good. So don't even think that my accent is not good. I can't talk fluently. It doesn't matter. We have seen hundreds of students who I even don't understand sometimes what they are saying, but they passed in their first attempt. How? Because their communication was good. They were polite in the exam. That was the reason. So I always say that use an alternative approach in the psychiatric cases. Start in a way so that examiner starts to listen to you. An examiner feels interested that, well, this candidate is a little bit different than others. Let's see what this candidate has to offer. Once you have given the confidentiality approach, then you start your questions. This session, Dr. Gayan, you don't need to record it. We will give the recordings in the Facebook after the class. So, psychosocial history. Once you have given this, you ask the patient, can you tell me a little bit more about what's bothering you? We always start with an open-ended question. The patient will give you some information. If there is something very sad, then you always say, sorry, I'm sorry that happened to you, but I need you to ask, or I need to ask few questions so that I can help you appropriately. After you have done that, you start your questions. The psychosocial history starts with mood, sleep, and appetite question. So ask the patient, how is your mood these days? If patients say, I feel very low all the time, many people I have seen that they ask about what is the score of low mood from 1 to 10. You don't need to do that. It doesn't give you anything. Forget about scoring the mood. The important question would be that you can ask that sometimes do you feel really high? Why? Because by that way, you can rule out the possibility of bipolar disorder. So if sometimes they are feeling low and at some other time they're feeling very high, that means there is a possibility of bipolar. So that you can ask. After that, sleep and appetite. How is your sleep and appetite? Patients say, I can't sleep properly. What you would say? I'm very sorry. So then you ask a little bit detail about the sleeping issue. So you can ask, do you get difficulty to fall into sleep or do you get up early in the morning? The reason why we ask it that if someone having initial insomnia, which means having difficulty to fall asleep, it suggests patient is anxious or having an anxiety disorder. Someone who is getting up early in the morning and can't go back to sleep after that, that suggests depression. You can also ask, do you get multiple broken sleeps or nightmare? If a patient says that I'm getting a lot of nightmare, it could be a case of PTSD or post-traumatic stress disorder. So those are the important questions for sleeping difficulties. And always ask the duration, that how long you are feeling this way. It's important to know because your diagnosis depends on the duration. After sleep and appetite, we ask about suicidal risk. Any psychiatric case, it's very important that you assess if the patient is risky for himself or others. So ask the patient, do you think your life is worth living? If patients say no, then you ask next 3 questions. Do you have any passing thoughts of harming yourself or others? If yes, then say, any definite plan to commit suicide? Any previous attempts? Do you have access to any weapons? If patients say at the first that, yes, I feel my life is worth living, then you don't bother about these questions. After you have asked the suicidal risk, then you move on to some of the other questions. So mood, sleep, and appetite, then suicidal risk, then we go for hallucination and delusion questions. So we ask the patient first, John, I'm going to ask you some screening questions that might seem quite strange to you. Is that all right with you? If you don't say that and you ask the patient that you see someone or do you see something that others don't, immediately patient will say, what, do you think I'm mad? I'm insane? Why you are asking me this question? And then candidate becomes very frightened and scared, and the case is ruined at that time. So that we just ask you to say this line before you ask this hallucination, delusion question, so that you don't get a confrontation from the patient. So after you have said this, say that we're asking about hallucination question. So do you see, feel, or hear things that others don't? See means visual hallucination, feel tactile hallucination, hearing auditory hallucination. This is also a part of perceptual disturbance in MSc presentation. So psychosocial history is a part of your task for MSc presentation. MSc means mental status examination. So we will come to this MSc presentation tonight. So MSc, part of MSc is perception, and perception is all about hallucination. Thought content is the delusion. So for delusion, we have 6 or 7 questions that we ask. we remember the mnemonic RCGGP. R means delusion of reference, C means delusion of control, G means delusion of guilt, delusion of grandiosity, delusion of persecution. For delusion of persecution, you ask the question, do you think someone is spying on you or trying to harm you? So this persecutory delusion has other names. So persecutory delusion, then you have paranoid delusion. So those are same. After that, for C is control. Do you think someone is controlling you? Do you think people are talking about you? So that delusion of reference. So delusion of reference, patient will say that whenever I walk on the street, I always see that people are talking about me. So that's delusion of reference. Do you think you are guilty of something? Do you think you have some special power? So that's again grandiosity and guilty. Now, do you need to ask each and every question? No, it's a relevant question. Someone who is having active hallucination and delusion, who is likely to be a schizophrenic patient, you don't need to ask about the guilt question. Guilt is mainly positive in a depression patient. Same in a depression patient, you don't need to ask that, do you think you have a special power? So it's not relevant for depression. But for schizophrenia or acute psychosis patient, all are relevant except the guilt. Guilt is not important for a schizophrenia patient. So we always ask the relevant question, not everything. There are few other delusion questions. So those are called thought insertion, thought withdrawal, thought broadcasting. Do you think someone is inserting or withdrawing thoughts from your mind? Do you think your thoughts are being broadcasted in TV or radios? All right, so these are all the delusion questions that we are supposed to ask. Very important question, especially if your case is a psychotic or schizophrenia case. Once you have done that, hallucination, delusion, then there is insight, cognition, and judgment. So for insight, we ask that, do you think you need some medical help? Especially patients who are schizophrenic or having active suicidal thoughts, they will say, no, I don't need anyone help. That means they have lack of insight. Judgment, we ask the question, John, assume that if there is a fire in this room, what will you do? Patient who has active suicidal thought, they will say, I will not do anything. I will stay here so that I can die. Patient who is schizophrenic, they can act differently. Some can say, I am messenger of God, fire can't touch me. Some can say, well, I will just run away. So it depends. Then we ask about the cognition. Cognition implies the orientation to time, place, and person. So we ask the patient, do you know where are you right now? So that's place. Do you know what is the date today? Time. And do you know who I am? Person. So time, place, and person. This is usually get abnormal in a patient who has disorientation. So can be in a psychotic patient, can be in a patient who is delirious. After insight, cognition, judgment, we finish always with this heads, SADMA, past medical history, family history, and ruling out any organic causes. So what is this heads? Heads is a very important part of psychiatric questions, but we don't ask all the heads. Heads, basically, it is a mnemonic for H for home situation, E for education, A for activity, D for diet or drugs, S for social history or support, and another is for sex. The important thing that we ask from heads is home situation, work situation, and support. So you ask the patient, how is your home situation? Who do you live with? Any stress at your home or at your work? Do you have any financial issues? Do you have enough support? So a couple of questions like this you're supposed to ask under the heads. Then we ask about SADMA. Throughout the course, you will come across these heads and SADMA. So SADMA, again, it's a mnemonic, but we mainly ask smoking, alcohol, recreational drugs, and any other medication. So do you smoke or drink alcohol? Any other recreational drugs? Are you on any regular medication? So that's SADMA, smoking, alcohol, drugs, medication. Ask about any past medical history or any past mental history. So any past medical condition or any past history of mental illness, any family history of mental illness, and lastly, finish with any organic cause. Couple of organic cause can mimic psychiatric presentation, especially head injury, hypo or hyperthyroidism, or any recent flu. So ask the patient for thyroid condition, any change in your weather preference, any head injury, any flu-like illness. Patient with thyroid problem, if it is a hyperthyroidism, they always feel hot. So they can't usually tolerate the hot weather. Just opposite is hypo, they can't tolerate cold weather. So we ask the patient that you have got any change in your weather preference and head injury, flu-like illness to rule out any organic cause. So that will be your history format for all psychosocial history that you are supposed to take in psychiatry. And you will be able to use this single format for any psychiatric case. So to give you a summary, first, we start with greeting politely. We give confidentiality as an alternative approach. Then we open with an open-ended questions. Then start with mood, sleep, appetite. We ask suicidal risk, hallucination, delusion, insight, cognition, judgment, heads, SADMA, past medical history, family history, organic cause. Oh, good. So that will be your psychosocial history. Anything that you haven't understood so far? Any question? Dr. Irene asks that, do we have access to notes for tonight's session? No, unless you are our course student, you don't have access to any of the notes, but the recording of tonight's session will be given on the Facebook group. So you should be able to go through that if needed. So you don't have any questions so far, I guess. Moving on to MSc format. So most of the cases, we are doing the MSc questions today. So they will ask you that a patient coming to you with a suicidal attempt and the wife brought the patient to you because of that. Your task is to take a psychosocial history. And the second task is to present MSc to the examiner. So you take history from the patient and you present MSc to the examiner. So psychosocial history has everything that you need for this MSc presentation. So how we do the MSc presentation? We follow this aseptic J3R. So what is this aseptic J3R? Whenever you get a MSc presentation, when you go inside the room, you write aseptic J3R on the paper. Because the findings you are going to get from the history, you need to give it in the MSc presentation. So aseptic J3R, it means A for appearance and behavior of the patient, S for speech, E for emotion, which has mood and affect. We will come to that. Then P for perception, T for thought form, another T for thought content. Don't forget there is 2T. Lot of people forget this. Then I for insight, C for cognition, J for judgment. And lastly, finish with 3R, which means risk, rapport, and reliability. So this is the way of presenting MSc to the examiner. Now we will move on to what does it mean. So appearance and behavior. So when you do the MSc presentation to the examiner, you say that, dear examiner, I would like to present the mental state examination of my patient, Mike, a 35-year-old doctor who was found by his partner trying to hang himself in the garage. So you give an idea about the patient. Let's say this was the case. After that, you will say that in terms of appearance and behavior, so in your appearance and behavior, you comment on these 5 things. How well the patient has dressed. So is the patient dressed appropriate to the weather? Is he well groomed or unkempt? Is he cooperative or not? Is he maintaining eye contact? And any abnormal body movement or posture. Abnormal body movement can suggest some specific psychiatric condition, like if a patient is on a stooped posture, leaning forward, likely chance he is depressed. Constant fidgeting, constant moving the hands, then constant playing with the legs are moving constantly, suggests that patient is anxious. Restless, agitated, and running around the room, likely patient is manic. Distracted, seems to be responding to some unseen stimuli, likely to be schizophrenia. Many times, appearance and behavior gives you an idea about the case. And if you miss the clue the patient is giving to you, likely chance you're going to fail the MSc case. This is the most important part, because let's say it's a schizophrenic patient. Throughout your history, you have noticed that patient is looking on some part of the ceiling or wall, as if he can see someone. Or patient is pretending that he can hear someone, but obviously you can't see anyone. And at that time, this thing you have to say. You have to say that my patient seems to be distracted and responding to some unseen stimuli. So very commonly they give this to you in the exam. So they give you a schizophrenic patient, and the patient actually looks at a certain point on the wall as if he can see that person. That means patient having a visual hallucination. All right. So in appearance and behavior, you are commenting on how well the patient is dressed, if the patient is well groomed or unkempt, cooperative or not, maintaining eye contact or not, or any other abnormal body movement or posture. Then you move on to speech. In terms of speech, speech can be normal in rate, volume, and tone. So if a patient is responding to you in a normal voice, not very loud, not very slow, your comment will be speech is normal in rate, volume, and tone. There are few other findings in speech. If it is a depressed patient, most of the time they talk in a slow, monotonous speech. So slow, obviously you understand. Monotonous means if you ask that, do you think your life is worth living? Patient just answer no. Do you feel very sad these days? Yes. So just single answer to your all questions. That's a monotonous speech. And the depressed patient will be very slow, right? So slow and monotonous suggests depression. Rapid, pressured. If a patient is very loud and just talking throughout the time, not giving any pause, that's a rapid pressured speech, and you find it in a mania patient. So other than that, many times depression patient will give a good amount of pause in between each sentence he says. Mania patient most of the time doesn't answer your question appropriately or spontaneously. And psychotic patient has a disorganized speech. Many psychotic patients in the exam will have a normal speech because otherwise they can't make the case. But there are cases, like a real case, in which you can't even understand what the patient is saying. That's also a schizophrenia or psychotic case. So speech, you comment that if the patient having a normal rate, volume or tone, slow monotonous or rapid pressure. How you know that this is a MSc case? Because in the exam, they give you present mental state examination to the examiner. So mental state examination means MSc presentation. So it will be given in your task. After the speech, we move on to the emotion. So emotion is divided into two parts, mood and affect. Mood means what patient says when you ask the patient, how is your mood these days? Patient say, my mood is very low or I feel very sad. Whatever patient says to you, that's the patient's mood. If patients say that I'm all right, you say that according to the patient, his mood is all right. If patients say low, you say according to the patient, his mood is low. So what is affect then? Affect is what you observe in the patient in terms of his mood. If a patient saying my mood is all right, but you can see that patient looks very gloomy, patient looks very sad, then you say that patient says his mood is normal, but the affect I have observed is not congruent with his mood. So affect means as an examiner, what you actually think about this patient's mood. So it's your perspective. Okay, so if patient say I'm very low, I'm very sad, and patient looks very sad to you, then you can say according to the patient, his mood is low and the affect I have observed is congruent with his mood. After that, you go to the perception. So you have done accept. So P for perception. Perception is nice and easy, hallucination. So if you have got any kind of hallucination, you say in terms of perception, patient having auditory hallucination, but no visual or tactile hallucination. So it's about whatever finding you get in the exam. After perception, you have two T, thought form and thought content. So thought form. Thought form is a little bit difficult topic for you to understand. Try to get the basic idea. In a normal person, if you ask a question and they answer your question spontaneously without doing any other stupid things, then the thought form is linear, which means if a person, even if a schizophrenic patient, if he's answering your questions spontaneously and appropriately, that patient's thought form is linear. So linear thought form is normal. There are lots of abnormal thought form. One of them is called loosening of association, which you find in schizo or any other psychotic disorder. Loosening of association has some subdivision. One of them is tangentiality and circumstantiality, which you can find in a schizo patient. There is concrete thinking and flight of ideas. Let's discuss a little bit about this. What is this loosening of association, tangentiality, and circumstantiality? A patient who has schizophrenia or psychosis, let's say you have asked a question. What did you do today? What are you planning to do today? In case of loosening of association, you will not understand anything patient is saying. There is no relevance of your questions to the patient's answer. So patient is saying blah, 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 a lot of other things, but did not answer your question. So what are you planning to do today? Oh, my name is Arshan. I read this book. I want to see a movie. I don't know that supermarket had a lot of things to buy. Oh, that fish market had a lot of fish. So that means that there is no relevance of what you asked to the patient's answer. Now, coming to that idea, there is two topics called tangentiality and circumstantiality. If you ask a question and patient is saying a lot of things, but at the end, patient answered your question. That's circumstantiality. So a lot of things they have talked about, but at the end says, oh, I am planning to go to the movie today. So they have answered your question at the end. That's circumstantiality. Remember, it's a circle. That means they start with a lot of things and then they come back to the answer. Whereas tangentiality, they will never answer your question. They will just talk and talk, irrelevant talking, and never answer your questions that you have asked. All right? So that's how we say what is loosening of association, tangentiality, and circumstantiality. What is concrete thinking? It's called like as a human being, we are supposed to understand the verbal and non-verbal cues. And also, we don't give literal response to questions. Like if I ask you, how do you feel? And the patient say, I feel with my fingers and toes. That's the concrete thinking. If a patient does not understand a proverb, that's likely that patient having a concrete thinking. So these are all findings that we can get in a schizo patient, but in exam, usually you don't get it positive because they need to give you something so that you can present this case. So they don't give a case who has loosening of association, tangentiality, or concrete thinking. The next thing is flight of ideas, which is very hard to differentiate between loosening of association. Flight of ideas means that patient, when you ask a particular question, they jump from one topic to another. So one topic to another, they are just jumping and jumping, but each of this sentence they are talking, they have some connection. Like I can show you some example. So this is an example of flight of ideas. I loved that movie. I'm going to watch a movie with my mom. My mom adores me. So see that everything, every sentence patient is talking, everything has a little bit of connection, but they're jumping. I love that movie. I'm going to watch a movie with my mom. My mom adores me. None of them has an absolute connection, but at least a little bit. My father sent me here. He dropped me in a car. The car is yellow in color. Yellow color looks good on me. So you can understand that there is a little bit of connection, but in case of loosening of association, there will be no connection. Like this one, I should go for a walk. I feel like having a chocolate. I need to study for the exam. Oh, that movie has received a very good reviews. So when there is no connection at all, that's loosening of association. When there is a little bit of connection, but patient jumping from one topic to another, that's flight of ideas. And flight of ideas is a finding for manic patient. Mania comes in exam, schizophrenia comes in exam, depression comes in exam. So you need to understand this finding so that you can find out this in the exam. After thought form, the next thing is thought content. Thought content mainly is all about delusion. So all the delusion questions you asked, that gives you the thought content. So if you have got delusion of grandiosity, delusion of control, delusion of reference, you give this finding here. Thought content also includes two other things. Any overvalued ideas, like if a patient having eating disorder, like anorexia nervosa, bulimia nervosa, body dysmorphic disorder, that overvalued ideas is also under thought content. If a patient has obsessive compulsive disorder, obsession also under thought content. So these cases also come in exam as part of AMC presentation. So please remember it. After thought form and thought content, then we have insight, cognition, and judgment. So inside, you know that if patients say, I don't need any medical help, you say insight is poor. If patients say that, yes, I need help, then insight is intact. Judgment, either judgment is poor or intact. Cognition, if the patient is oriented to time, place, and person, then you say patient is oriented, otherwise not oriented. So insight, cognition, and judgment, then 3 are. One is risk. Risk, usually you need to find out if the patient is high risk or low risk. High risk means if a patient has active suicidal or homicidal thought, if a patient having active hallucination, active delusion, if a patient have no support in the shelter home, doing lots of drug abuse, those are high risk patients. But any patient who has active suicidal thought, hallucination, delusion, those are high risk. If a patient doesn't have any of those are low risk. Rapport. When you asked questions to the patient, if patient was answering questions appropriately, then you say that you were able to maintain a good rapport with the patient. Now, many times, especially manic patient or schizophrenic patient, they will not answer your questions appropriately. And that's not your fault. You have tried. And you would say that my patient was not answering my questions appropriately, and I was not able to maintain a good rapport with the patient. So always be honest. Reliability. Is the history that was given by the patient is reliable or not? It depends. If a patient having active hallucination, active delusion, active suicidal thought, that patient's history is not reliable. In that situation, you say that I would like to take a collateral history from the family member, neighbor. If the police brought the patient, then from the police. So anyone accompanying the patient, you take a collateral history from them. But if a patient having just mild to moderate depression, no active hallucination delusion, then their history is reliable and you don't need to take a collateral history from anyone. Okay? Is this understandable for you, that how this aseptic ZPR will help you in the exam? Now I'm going to show you how actually you are supposed to present MSE to an examiner. Okay? And that will clear up your confusion. So you will say like this: Dear examiner, I would like to present mental state examination of my patient Mike, a 35-year-old patient found by his partner trying to hang himself in the garage. In terms of his appearance and behavior, he is well dressed, appropriate to the weather. He is well groomed and cooperative, and he was not maintaining eye contact throughout the conversation, but he also did not have any abnormal body movement or posture. In terms of his speech, it was very slow and monotonous, but there was no rapid pressured speech or disorganized speech. We always give some negative finding with positive finding. In regards to his emotion, he said his mood is low and the affect that I have observed also congruent with his mood. There was no hallucinations in terms of perception. His thought form was linear and there was no loosening of association or flight of ideas. In terms of thought content, he had delusion of guilt, but there was no delusion of reference, control, or any thought withdrawal or broadcasting. He was oriented to time, place, and person. His insight and judgment was poor. He is in high risk because of active suicidal thought. I was able to maintain a good rapport with my patient. The history that was given was not reliable because of his active suicidal thought. So I would like to take a collateral history from his roommate or anyone who is accompanying him. Thank you, examiner. You are not supposed to give the diagnosis of a case when you present the MSc, unless it is your task. So a lot of candidates, they think that MSc presentation also means giving the diagnosis and differential. No, it's just what you have found in your psychosocial history. Is this clear for everyone how you're supposed to like present the MSc? Any question? Very good. Let us take a 5-minute break. And after that, we will do few cases. And I would advise any of you who has started your preparation, who knows about how to do a role play, just get prepared. We will do at least 1 to 2 role play about some of the case so that you can understand what is a role play. You will hear this term a lot, role play, and role play. So we'll show you how this role play usually works. All right. So let's take a 5-minute break and then we can start it again. If you have any question, just let me know in between that. Thank you all. All right, everyone, let's start again. So we're going to do some cases. Now let's do a, sorry. So let's do a role play on one of the AMC case, which is very, very important for your exam. So who wants to do it? Anyone who is interested to do a role play here? Anyone? Should be someone who wants to do it. And it's totally fine. You might be thinking that I don't know any of these people in here and what they will think about me. Let me assure you that if you can do it in front of 80 people, in the exam in front of one person, it is nothing. Okay? And when you start doing this kind of role play with a lot of people in front of you, you get a huge amount of confidence, and which actually helps you to pass the exam. Okay, so feel free to do it. Even if you do mistake, that's fine, because you are just learning. And if you don't do mistake, how you're going to learn? Okay, so it's a part of your learning. Even if you're not sure, that's totally fine. We can always see how you're doing, and then we can show you the correct approach. Anyone? Enough breath? Very good. Okay. I am just unmuting Navpreet for now. Just let me know when you are unmuted, Dr. Navpreet.
Hello, Dr. Ashan. Can you hear me?
How are you? Yes,
I'm
I
good.
can hear you. I'm good, thank you. All right. It's a good job that you are doing to do the role play. And just don't get nervous. Don't feel that there's a lot of people here. Just think that you are doing a role play in front of me. That's it. And anything that you do is totally fine. Okay?
Okay.
I'll just stop my sharing just for a minute so that I can give you the case. Just hang on a minute. So this is your case. We'll do it as 2 minutes outside for your preparation and 7 minute 30 second inside. We don't give you 8 minutes because if you can finish a case in 7 minute 30 second in exam, 8 minutes is nothing for you. Okay, so 7 minute 30 second in the inside and 2 minutes outside. So your 2 minutes just started.
Okay.
All right, so this is your patient. Your patient name is Sam. You can start.
Dr. Ishan, I have just one question.
Yeah,
Like I can't comment on the appearance in this case. So how would I
that's
be?
fine.
Okay.
You will just say that appearance cannot be defined, something like that. Okay.
Okay.
All right, so
Uh,
let's start.
okay. Okay. So this I'm presenting a case of 47-year-old patient who just had his surgery 1 day ago for the dislocated right shoulder, and he's reported to be having a long history of alcohol intake in the past. And I'm starting with the mental state examination. In appearance, I can't comment on that. With the behavior, at the moment, he's aggressive. And
You need to take a history first, now Dr. Navri, to do the assessment. So let me just stop you here. So what we
okay.
say here is that your first task is to do a psychiatric assessment, which means you need to take a history. So think about the psychosocial history that we have done. Okay, so you'll start with a little bit of gentle approach, and then you give the confidentiality to the patient. And after that, you start taking the history, mood, sleep, appetite, suicidal risk, ask all the aseptic J3R. You find out the finding from the patient. So that's your first task. And after that, you will present the AMC to the examiner.
Okay. Uh,
Okay.
okay. Hello, Sam, Dr. Navpreet. I can see I can see that you are really stressed at the moment. I'm really sorry for that. But I want you to know that I'm here to help you in whatever manner. Uh, and whatever
Oh,
we
doctor,
discuss.
there is lots of cockroaches on my whole body.
So,
Just
yeah,
take me out of this hospital. I can't live here.
you
It's
don't
full
worry
of
about that.
cockroaches.
You don't worry about that. We will take care of that. And
You need to
we will.
take care of it right now, doctor. I can't stay here. This is a hospital, and hospital shouldn't have cockroaches. How a hospital can have cockroach? There is a cockroach just on your shoulder, doctor. Just remove it, please. Oh my God, what a filthy hospital it is.
Uh,
Just
I
let me
can
go.
assure
I
you
just
that.
don't want to be here anymore. I'm fine. I just need to go.
I can assure you that we will take care of everything. You don't need to worry about the cockroaches. And it's just that you are seeing these kind of things. And at the
What do you
moment,
think? I'm insane? Do you think I'm a mad person? I'm not mad. These are cockroaches. I'm not seeing anything. What are you referring to?
I'm saying sometimes you see things which are not there. And but some people
No,
will
yeah,
not perceive these
that's
concepts.
absolutely wrong. What the hell? My doctor is thinking I'm an insane person that I see cockroaches. There is cockroach all over this table.
I'm not saying that you are insane at the moment, but sometimes things which would be there in front of you will you can't see, like they will not be there. And I'm not saying that you are insane or you are like in some mental state, different mental state. It's just that um, it's difficult to do that
That's fine, Dr. Nabri. I know this is a very, very tricky thing. Okay.
because I don't know
Don't,
what to say to this patient.
yeah,
Okay.
yes, I understand. Well, I will show you how to do it. Don't worry. Okay. But you did it. You are doing really good. The initial thing that the thing is important in these cases that never say that patient is wrong. Patient is always right. Don't say that you're seeing things or anything like that. I will tell you what to do in these cases. Okay. So let's just stop here, Nabrit. I will
Okay.
see that if I can find anything from Dr. Iranga, and we'll do this case, and after that I will discuss what exactly we are supposed to say here. Okay, you did good.
Okay.
Don't worry. Dr. Iranga, you want to do it now? I have unmuted you.
Hello.
Hi, Dr. Iranga. So,
Hello, can you hear me?
yes, I can hear you.
Yeah. Yeah.
Okay. You're ready to do the case? Do you need any like 2 minutes for reading the case?
Yeah, I saw the case.
Okay. Let me give you 1 minute time and then we can start. Okay. Okay, Dr. Iranga, let's start.
Yeah.
So this is your patient. Your patient name is David. You can start.
Yeah, David, I'm Miranga, the doctor in the ward today. What do you feel, David? What's bothering you?
There is nothing bothering me, doctor. I just want to go out. This is a filthy hospital. This hospital has cockroaches all over my room. I just can't live in here. You have done a good job by fixing my shoulder and just let me go now. I don't want to stay in these filthy, stupid places.
Yeah,
this is a government
understand.
hospital and you are supposed to take care of the hospital. You're supposed to take care of the room. Where is the cleaner? I haven't seen the cleaner in the last 3 days. There is cockroaches all over. I can't eat anything. I can't even sit on my bed. I just want to leave. Just let me go.
Yeah, David, I understand your concern. Now I ask the cleaner to come here now, and he will come definitely and we'll clean the room. And I want, we have to do some checks on you with this shoulder surgery. So I just wanted to keep you here to check that, and we'll ensure this place is clean, David.
Okay, do it right away. I can't stay here for long.
Yeah, I understand. So David, other than you see that this place is not tidy. So did you see in this
There is
cockroach?
cockroaches everywhere. Yeah, there is cockroach everywhere. Can't you see, doctor? There is all cockroaches, even one on your shoulder, just on your right shoulder.
Yeah,
have a look.
Yeah, I understand. Yeah. So David, do they disturbing you? Do you hear someone is telling you also, is there any cockroaches?
No, doctor, I'm not insane.
No, yeah, I understand. Yes. So anyway, the cleaner will come in 10 minutes, like, and he will clean this. Were you able to have a good sleep, David?
No, I can't. All I see is cockroaches all over. I can't sleep. I can't even lie down or sit down on anywhere because all over I can see is cockroach.
Have you tried to remove them?
Yeah, I have, but they're all over. How can I remove it? I'm just a patient here. The cleaner is supposed to do this.
Yeah. He's supposed to do this. That's true. So regarding our surgery, so are you happy with it?
Yeah.
So we have to give some medicine to you. So do you like to use the medicine?
Yeah, sure.
Okay. So do you know where you are now?
Yeah, in the hospital, which is very filthy.
Yeah, great. Yeah, great. So how about your appetite? Were you able to have the meals?
Yeah.
Yeah, great. This is this when I ask you this, you will feel between whether I'm mad, David. But I'm just asking. We are asking this question from each patient. So once in a while, have you feel your life is not worth living?
No, my life is worth living. I just want to leave this hospital so that I can live happily.
Yeah, great. No. And definitely we'll be treating you and the cleaner will be coming. So we'll ensure and sorry for your discomfort. So David, do you have any fixed beliefs? Now you think the the room should be clean. That's true. So like that, do you have any fixed beliefs?
No.
No. Do you think someone is spying on you?
No.
So do you think others are talking about you?
No.
Someone is trying to control you?
No.
Oh, great. So do you hear others are talking anything to you like that?
No.
In your, do you feel someone is itching, pricking on you, or someone is hurting you like that?
No.
Yeah, great. So David, do you think now we did the surgery for you? Do you think this surgery is effective to and whether it was helpful to you?
Yeah.
Yeah. So David, let's assume there's a fire in this room. So what you are going to do?
There is fire in this room. Where is the fire? Now there is fire as well.
No, there isn't a fire. I just ask if we think there is a fire in this room. If there is a fire in this room, what you are going to do?
I will run away.
Yeah, that's true. I also do the same. So David, have you before the surgery, were you on any drugs or did you had any significant medical conditions?
No.
No. So do you consume alcohol usually?
Yeah.
Yeah. Do you know what's the amount, how frequently you consume?
Usually 6 to 8 drinks of wine.
Yeah, daily.
Yes.
Yeah. So you missed it these days, no?
Yes.
Yeah. So usually do you like to have wine in the morning? Whenever when you
most of the
wake
time.
up? Most of the time. And
Yeah.
have you attempted to quit alcohol?
No.
No. You think you need it?
Yes.
Yeah. So now the cleaner will be coming, David. So we'll ensure, and I want to give you some drugs, and with some drugs also we can help you to have a good sleep. And you told that you were not able to have a good sleep in the past 2-3 days, and so we want to help you, David.
I'm of Dr. Iranga. You're doing good. So present the MSc, Dr. Iranga.
Hello.
Yeah,
Dr.
your
Amar?
time is up, but you can present the MSc. That's fine. So just present the MSc to the examiner about your findings.
My patient is Mr. David, and he was admitted to the hospital following. He's in the post-op. He's on post-op management, and he was complaining of visualizing cockroaches. So according to the history, I think I couldn't assess the appearance of the patient, but his speech was rapid and with pressure. And I think his mood is elevated. And he was having visual hallucinations, but no auditory or tactile hallucinations. His insight was good, and insight was good on the medical condition regarding the surgery, and his judgment is good, and his cognition was good. I think he's having visual hallucinations and a possibly a delirium status, maybe due to alcohol withdrawal, because there's a supportive history of consuming alcohol, and tried to assess him through the Craig questionnaire, but I'm not quite sure of the component. But he was not having any significant medical illnesses. Probably he may be a patient with schizophrenia, or he may be, this presentation may be due to alcohol withdrawal, and this need the psychiatric assessment.
Thank you, Dr. Iranga. Okay, again, no need of giving the diagnosis. That's not important for AMC because that's not your task. Okay.
Okay.
So, Dr. Iranga, you did really good. I'm really happy with your approach, how you managed to be calm in this case. That's really an important part. If you can be calm with these kind of cases, you can do any case. So very good and well done. But we will just show you now that how, like, what are the other things that Dr. Iranga has missed, especially in the AMC presentation. But this is obviously her maybe just she has done some role plays maybe, but obviously this is very first for her as well. As a first time, it's really good.
Yeah.
So
Yeah,
Dr. Iranga, I'm going to just, this is your first time. So as a first time, this is absolutely good. Okay, so very well done. I'm going to just mute you for now so that we can discuss this case.
Thank you. Thank you for the opportunity.
Thank you. No worries, thanks. So as you can see, a typical psychiatry case, especially the MSc presentation, looks like this. And you can understand how nerve-wracking it can be in the exam. So I'm not a professional actor. Think that a professional actor will be in your exam and what they can do to you if you are not calm and you don't know how to really approach these kind of cases. So that's why we say that psychiatry is something that you really need to learn. You need to find out your approach. You need to find out which communication makes the patient calm. Okay. Now, if you think that if we never ever say that you are wrong, like patient is wrong, that's never. Patient is always right. If patient is seeing a cockroach, he or she is seeing a cockroach. But we can't say that, yes, I can also see a cockroach. That's also not the case. So you as a doctor needs to be a little bit smart. You never say that you can see the cockroach, and you also don't say that you are insane or you are seeing a cockroach or under pressure. Sometimes we see something. We never say anything like that. Patients in these cases are very sensitive. If you say anything like that, fail. So normally in this case, how Dr. Iranga has done, if you just be calm and just go with the flow, you will be fine. It's just about, patient will say that it's all over, there is cockroaches. Patient will most of the time just cockroach, cockroach, and cockroach. So every time patient saying something like that, you always say, I'm really sorry for this. I understand it is very frustrating for you. I called the cleaner, he's on the way, and he's going to come and clean the room straight away. Please wait a little bit, and I need to ask you a few questions regarding how is your surgery, how you are doing after the operation. And obviously in between that, the cleaner will clean the room for you. Again, I'm really sorry that you had to go through this. The one thing that Dr. Iranga did not say is the confidentiality statement, which is must for this kind of cases. That's the main issue, because you are very nervous in the exam, especially on the top of that, patient is doing something like that. He's confronting you, he's getting angry, aggressive. You lose the track of your format. In your head, you have a format, but you can't think what should be my next question. And on that way, you forget the most important part, which is the confidentiality statement. Without confidentiality statement, psychiatric cases most likely will be failed. So that's actually very important. There is no critical error in exam anymore. There are 3 to 4 key steps. In psychiatry, one of the key steps is ensuring appropriate confidentiality to the patient. So you just missed one very important key step if you don't do that. So the confidentiality is that much important. So you always start in that way. Hi David, this is Dr. Arshan. I'm one of the HMO in the surgical ward. I understand that you are under some stress. Can you please tell me a little bit more about it? Even what happens in these cases, when you go in, patient starts talking. So you don't even get the time to say anything like that. Patient will say all the things that I said or something else, but mostly about cockroach. You say that I'm really sorry that you are having this issue. I know that this is very frustrating. I have already called the cleaner and he's on the way and he's going to come and clean the room straight away. In between that, David, I need to ask you a few questions about your surgery and also need to examine, also need to check you how you are doing now. I want you to know that whatever we are going to discuss here today, it is confidential between you and me, unless it is harmful for anyone, harmful for you or anyone else. Is that all right with you, David? Yes. So when you give the confidentiality, you say cleaner is on the way, patient starts to become calm. Never become fully calm, but they will answer your questions if you show your empathy, if you become a little bit polite, if you don't confront the patient, they will be calm. So after that, then you remember one thing, you write the aseptic J3R on your paper. Every time you get a finding, you just write appearance. If you think that patient is unkempt, you write. If you think patient having like not having some unusual behavior, you write it here. Whenever in the speech, you can write a rapid pressure, just something that you can remember. In the emotion, you write about what's the mood. If patients say low, then you write low. So just write the key thing. If you don't do that, in your MSc presentation, you will forget. And also you will forget the important questions. Like Dr. Iranga did not ask about emotion at all. That means how is your mood? That's the exam pressure, you will forget. So first you start with, in such cases, we can start with the most important thing. So it doesn't mean always you need to start with mood, sleep, appetite, suicidal risk, hallucination, delusion. You can play around. As long as you're asking questions, you're fine. So patient seeing cockroach, you can start with hallucination question first. You can say that, David, I can understand that there are all over this room, there are cockroaches. Can you please tell me that, are you also hearing some things, that if someone is saying something to you? If patient said, no, do you think I'm insane? You just say, I'm really sorry if you are feeling this way. These are some screening question for everyone. Please don't think that you are insane. You are absolutely right. Okay, so immediately say that it's not something that you are crazy. After that, you ask, can you also feel the cockroaches on your body? Why? That's tactile hallucination, which was positive in this case. If you don't ask something in your history, never say in the MSc presentation. Like if you say in here that there was no tactile hallucination, but you haven't asked it, which means that one, that you lied about your MSc presentation, which you something did not do. That's something which in the exam that makes a very bad impression. If you forget to ask something, you say that, I'm sorry that I forgot to assess the tactile hallucination of my patient. If you say, examiner can pass you, if they feel that, well, this candidate is honest, I will not fail her just because of this. But if you did not assess something and then you say that something else in your presentation, examiner will not be happy about it. Okay, so important thing is being very honest in the exam. If you haven't done something, you can always forget. Just say that I did not assess it, I'm sorry. After that, you find out about the hallucination question, then you can move on with your format. So ask about the mood, sleep, appetite, suicidal risk. Then you go to the delusion questions, then insight, cognition, judgment, and that's how you will finish it. And at the end, just quickly ask about heads and SADMA. Now, it's all about your timing. Your task is to do a mental state presentation to the examiner. Even if you don't ask heads, you will not fail this exam. If you don't ask SADMA, you will not fail this exam because you have asked everything that is needed for mental state examination. Okay, so it depends on your time always. If you think that you will run out of time, you will just finish when you are finished with aseptic J3R. But if you have a little bit of time, then quickly ask, how is your home situation? Any stress at your work? And do you smoke or drink alcohol? Patient will say yes. How many alcohol you used to drink? How long you are not drinking? You don't need to assess the alcohol dependence in this case. These are irrelevant in here. So no need of case questionnaires, anything. Your task is not about diagnosis, doesn't matter. Okay, if you have time, you ask it, otherwise no need. After you have done the aseptic J3R, then you go to your MSc presentation. So I have written in here your history, so confidentiality. You time to time always say that, I'm very sorry for your frustration, the cleaner is on the way. So whenever patient says something about the cockroach, you always say this line, I'm very sorry, please bear with me, please wait a little bit. So just keep the patient calm. I've written everything in here. So whatever we have discussed, everything is written. Now, how to present the MSc? In this case, when you write the aseptic J3R, you'll know what to say about. So you will say, dear examiner, I would like to present the mental state examination of my patient, Peter or David, a 57-year-old who was behaving oddly after surgery. In terms of his behavior, he seemed quite aggressive. He was very loud, but dressed appropriate to the weather. But patient looked unkempt, and also he was maintaining eye contact throughout the conversation. He was uncooperative initially, but after proper confidentiality, he became cooperative. In terms of his speech, it was rapid and pressured, but there was no slow monotonous speech or disorganized speech. His emotion, he told that he is all right, but the affect that I have observed is not congruent with his mood. He seems to be disturbed. In terms of his perception, he was having visual and tactile hallucination, but no auditory hallucination. Okay, so as SEP we have done. Then 2T, his thought form was linear. He was answering questions appropriately. There was no loosening of association or flight of ideas. In terms of thought content, there was no delusion. His insight was intact. His judgment and cognition was also intact. In terms of risk, he is in high risk because he's having active hallucination. He seems to be aggressive, and also he must be having some alcohol withdrawal symptom. I was able to maintain a good rapport with my patient, but the history that was provided by the patient was not reliable. So I would like to take a I would like to take a collateral history from the nurse. In this case, you can take a collateral history from the nurse because there was no one else with the patient. That's it. And you thank the examiner. Okay, clear everyone? So that's how you are supposed to do this case. So Dr. Audrey asked how to describe patient's mood. It's always, when you ask the question, how is your mood? Patient will say, I'm all right, I am low, I'm sad, I feel angry. So that's the mood. So whatever patient says, that's mood. The affect is what you observe. If patient said that they're all right, like in this case, if patient say, I'm all right, patient is not all right. So you say that the affect that I have observed is not congruent. It seems to be disturbed. Okay? Dr. Go, are we allowed to write down our history during the consultation? You can, but it takes a huge amount of time. You don't have enough time in your exam to finish even. So if you write a lot of your history, you are going to run out of time and you will not be able to finish your task. I always say don't write your history, but for aseptic J3R for MEC presentation, write it. At least your finding. Okay? After we enter the exam, we write down aseptic J3R first, then we start greeting patient as we go through every criteria. Can we write? Yes. Briefly on the paper, your finding, you can write. How much time I should spend in history taking? It always depends on the number of tasks you have got. In this kind of case, history is a little bit more detailed history. 8 minutes, you can divide this case as 6-minute history and 2-minute MSc presentation. That's what you should do. If there is a 3 task, then we divide it into like 4-minute history, 2-minute physical examination, 2-minute diagnosis and management. So it depends on the number of tasks you get in the exam, you divide the time in that way. Sometimes patient speech is such that you can't get most of the word. Again, a psychiatric patient can say a lot of irrelevant thing, which is not even important for your MEC presentation. Like if it is a mania case, you will say a lot of things which even you don't need to. So use those things which you can't understand, it's likely that it's also not needed for your MEC presentation. Okay, so if you can't understand something, you just say, pardon me, or I'm sorry, can you please repeat it again? Dr. AK, do we have to finish telling the examiner before the bell rings? If bell rings in between the presentation and we haven't finished, do they fail us? Good question. According to AMC Clinical, you are supposed to finish your task before the bell rings, or at least when the bell rings. If bell rings, you are supposed to stop. Now let's say you are just about to finish. They will not be that much cruel to you that you can finish a little bit of small lines. What we say that, let's say a very important thing you haven't said. You should not sit and talk when the bell rang. You stand up and on the way of your out of the room, you just say these 2-3 lines. Okay, but obviously you are not supposed to stay there because there is another candidate who is supposed to go into this room and they don't like it. So never do that. So you are supposed to get out if your bell rang. Is it necessary to say anything about stability here? No, no need of stability. Patient is aggressive, but he's not aggressive like he's going to like harm you or he's fighting, he's removing the IV lines, not something like that. So it's fine still. Can we interrupt the patient if continues to speak? No, no, not at all, Dr. Azra. We are supposed to never ever interrupt a patient when they're talking. It's a very tricky thing that how you manage to talk in between them. You will learn it throughout the course during your role play sessions, that how not to interrupt a patient, but also don't allow them to say a lot of things. Now, a patient cannot talk for 2 minutes without taking a breath. They can say highest 15 seconds, they need to take a breath. When they take a breath, that's the time you go in. You say something or you ask something that's relevant for you, and the whole thing rotates and you take the command. So as a doctor, wherever you practice, you will have a very gentle approach. Your communication will be fine, but the command is always yours. You make sure that you rotate the patient, not patient rotating you. Okay, but that doesn't mean that you will be unpolite. You will not allow the patient to talk. Patient will talk. Whenever they stop, that's the time you go in. Okay. Dr. Lina, is there a bell at 6 minutes and then final bell at 7 minutes? It depends. Sometimes if in the task, if they write history for 6 minutes, then at 6 minutes there will be a bell. But there is nothing written in the history about the minute, then there will be no bell. Just after 8 minutes, the final bell will ring. Most of the time, when the 8 minutes start, patients start to speak directly. Then what about intro and confidentiality? That's fine. In this case, patient will start speaking immediately when you go in. Patient will say, and they will obviously take a break. Then you start your introduction. You have to introduce yourself. You have to give the confidentiality. So patient will say a lot of things about cockroaches. Then you say, I'm really sorry that you are feeling this way. Let me introduce myself to you. I am Dr. Arshan, one of the HME in this ward, and I'm here to help you. That's how you start. Patient will take a break. They can't talk and talk. So whenever they stop, that's the time you start your case. Can we bring watch along with us? Never. They would not allow it to you. Is there a timer in the room? No. There is no timer. There is no watch. You never know what time it is. That's the irony in the exam. Both in online and face-to-face, you can't see the time. Only way to know is the bell. That's why you need to do a lot of role play. With role play, that thing comes into your head, that how much is actually 8 minutes. And that needs a lot of preparation, lot of role play. Without that, never ever you will be able to finish the case in the exam. So doing role play is the vital part of your exam preparation. If you think that if you will go into any course that's available, you will just read their notes, you will just do their classes, and you will pass the exam, that's a dream. Most likely never is going to come. So that dream will never come true because you will not be able to know that what is 8 minutes in the exam. And even though if you might know the case also, still you will fail that case because you will never be able to show the confidence in the exam. Confidence comes with a lot of practice, a lot of role play. And I would always say that please ensure you have at least 1 to 2 study partner with whom you do role play every day. Set up a time that every night from, let's say from 7 to 9, you will do 6 to 8 days role play with each other. That's how you do it. You time the role play and you give feedback to your study partner that this is something you haven't asked. This could be a little bit good if you say that. And when you join the course, you will see other people doing role play. We allow our previous students to come to the role play sessions so that they can also show you how to do an appropriate role play. So initially, when you join the course, our role play sessions also, we allow our past candidates and also who has already been prepared to show you the role plays. And with their role play, you also learn what to do, how to approach a patient, what are the different ways of approach. So everything you will understand, we will show you how to do it. You will also learn from others. So learning is always in a double-sided. You learn from us, you learn from your study partner, you learn from everyone who is doing good. And that's how the clinical exam preparation is supposed to be. It's not a vast preparation if you are smart. And we are going to provide everything that you need to pass this exam. What you need to do is to do that hard part. That means you need to know those cases, you need to read the pages, you need to join the lectures so that you understand how to approach, how to take history and everything, and do the role play. If you're new to the preparation, start doing handbook of AMC clinical exam, get a little bit of idea about the case until we start our course on 29th of April. So you still have got 2 to 3 weeks. In this time, I would advise you start doing the handbook. Even if you want to read with your study partner, just read the handbook cases. They have all the important information about some of the cases which also come in exam. All right. So this will be our tonight session. Now is the time that you guys are able to ask any questions about the course, any questions that you have about the AMC clinical preparation. Before that, I would go through a little bit of presentation about the course so that you understand what this course has for you. And most of the time with that, you should be able to know what is your questions, you will be answered immediately. So let me show you that first. And after that, we will allow you to ask questions. You can unmute yourself, you can write in the chat box. So that's totally fine. So just give me a moment. I will show you a video about our course now. All right, so let's have a look on the video. And most of the time, your questions are already answered by this video. If you still have questions, feel free to ask. So that's mostly about everything about the course. So basically the course has everything that's needed for any candidates to pass the exam. If we divide the classes, that actually comes as we have 3 classes in a week. 2 classes are mainly theory based. 1 class is role play. And role play covers almost every cases that is important for your exam. The theory classes also we do it as a subject wise and cluster based. The cluster based approach you will be able to know when we start our 2-week session. In the free session, we will be doing a cardiology cluster, and also you'll have some role play sessions. And those role play sessions are about random role play. So any questions can come and you are supposed to do the role play. Initially that becomes tricky, but again, when you get to learn the cases, it becomes easier. So we divide the classes like this. It's a 5 months course. And you might be thinking that why it needs this much time. Honestly speaking, you need this much time for your clinical preparation. If someone says that they can finish a course with 2 or 3 classes in a week and within 6 to 8 weeks, that's nothing. There is a lot to learn from this for this kind of preparation. 6 or 8 weeks course is not enough for AMC clinical preparation. We could easily do that because that will become much better for our course, because we can take 6, 7 course in a year, but we just take 2 course in a year. And with that 2 course, every class that we take, there is compassion in it. There is reason why we take the course this long. And that's one of the reasons why our candidates pass. It's not about just running course, it's about helping the IMGs to finish this and start their new journey in this country. So if we just think about business, then we can easily take a course which is 8 weeks, but that's not going to help you, because by 2 months' time, you are still very new with this preparation. And you will think that my course is finished, but I don't know where I am. I don't know anything about clinical preparation. That's what happens with these short courses. So that's why we make the course 5 months, so that you get enough orientation with the exam preparation. You get enough time to go through the cases, ask questions about the cases, because those initial 2 months, you still need to get along with the classes. After 2 months, then you start to gain your confidence. But after 2 months, if your course is finished, then you might need to get into another course just to understand the clinical exam again. So that's the main reason. But I understand that some of you might be in a hurry. That means you might have got an exam date. If someone is like that, who has already got an exam date, we allow you to do our course in your own pace, which means that you can finish your course in your own time by getting into our previous batch recorded classes. So we allow you to get into the previous batch, and then you go through everything by your own pace. And on the other way, you can also do our new classes in the new batch. So this is usually a case, if you have an exam date already, then we allow you to do that. Okay, so it's always there. And any of you, if you want to finish your preparation in 2-3 months, then yes, we should be able to do that case by case. You need to discuss that with us. But I would always say that it's never ever you will be able to finish everything in 2-3 months if you are a beginner, because we have got a lot of lecture notes, a lot of videos that you need to go through. So it's unreal to finish exam preparation within 2 months. It's not possible. All right. So please don't go for exam appearance, or please don't think that you are going to register for the exam with 2 months preparation, because that's not realistic. If anyone says that they have done it, it's really not I don't think it's the truth that they're saying. Maybe they have done 2 month total preparation, but maybe in the last 6 months, they were doing some preparation. but they're just saying about the last two months where they did absolute study. So time to time, you'll see that people are saying, I just had a 2 months preparation and I passed the exam. It is absolutely wrong. And it's not a guidance that you would like to follow. Okay. So apart from that, the course has everything as you can go through our course details. So theory classes, role play classes. We have 1 month physical examination, which covers every physical examination that can come in the exam. And physical examination is a vital part of your clinical exam pass. If you are a beginner, if you fail the exam, likely chance you failed because of physical examination. Okay, but we will discuss everything that you need to pass the exam. We also go through some of the job hunting, upper registration, and some other things in the course. You also will be able to get a class on that just in the next 2 weeks. We will give you an update about that so that you can learn about your pathways. All right. So go through the course details. We have written everything in your Facebook group. There is a website as well, which you can find in all the course details. So if you want to know a little bit more about the course, go to the First Aid AMC Clinical, the Facebook group, and then go to the featured section of that group. In the featured section, you will be able to see all the details. Okay. So let me go through your questions now. So if you have anything that you want to ask, you can ask by unmuting yourself as well. Dr. Annie, can we find a study partner through the course? Yes, you can. And that's the other thing, because it's a 5 months course. And in our course, there will be a huge number of students who get enrolled. But that doesn't mean that you will not get chance to do role play. I do the role play, subjective ones. Dr. Cynthia will do the random role plays. There will be enough time to do role play with us. If you are active, then you will be able to get enough role play chance. As you could see that today, only 2 people wanted to do role play. That actually the case in our classes as well. Most of the people, they don't want to do role play. But if you are active, if you are confident, you will get enough chance. Okay, so don't worry about that. And obviously, because there is a lot of candidates who are preparing with us in the 5 months, you get to learn people from your own country, from your own time zones, and getting partner is the easiest way like that. And we always help you to find a steady partner as well. To enroll the course, Dr. Iranga, you need to just either you send an inbox to me, or you can also use our email. The best way is email. So this is our email. If you use this email ID and send a email, we will always be able to help you with any questions. Dr. Gopinath, which handbook? So it's called the AMC Clinical Handbook, and that's needed for your preparation. You don't need to buy that. We will provide a soft copy when you start doing the course. Dr. Go, after enrollment, do we get access to the PowerPoint slide? Yes, every note will be there. All the class notes will be available into the portal until you pass the exam. The video access is for total 10 months. And 10 months, I don't think there is any course who gives you 10 months video recordings. But we give it to you so that you don't need to enroll into the course again and again. Once you enroll, 10 months is more than enough for your preparation and go for the exam. Okay? Is the physical examination course is a part of 5 months clinical? Yes, you don't need to enroll it separately. How much time is required for preparation? Dr. Jaina, everything depends on you. How much time you can give for your preparation. If you're not doing anything, if you are just at your home, not more than 5 months, enough. But if you are doing hospital job, you will not get enough time to prepare, then at least you should take 8 to 9 months for your preparation. On enrolling the course, after payment, all material is available at once to read. All the course notes will be available to read. We don't give when we take the classes, all the course notes will be available on your portal. What should be average preparation time? So I hope Dr. Tasnuva, you have got your answer. Dr. Go, if we finish the course months before exam date, do we still get access to the study material? Yes, you do. Can we postpone exam date? Yes, you can, but there is a specific time that you can do it, not just immediately before the exam. Physical examination is online. This is an online class, but you can ask to any of our previous students how we do the physical examination class. You don't need to be in a room or face-to-face to learn it. We do it in a way so that no one ever had any difficulty to understand the physical examination. It is absolutely okay. And even people do just our physical examination classes. Okay, so you don't need to worry about that. I wanted to ask Dr. Navkiran that can we give exam just a month after the course end? Yes, you can. If you do everything that we are doing in the course, 5 months is enough. I always say that take at least a month after the course end so that you can revise everything and then you can appear the exam. But if you are doing really good, you are doing study throughout the 5 months, there is nothing you need to do apart for it. You can go for the exam. How long usually we need to study for part 2 before sitting the exam? I would say at least 6 months is must. Is the course entirely online or there is no need of any face-to-face session? It is entirely online. Dr. Lena, after your daily classes, how do we initiate studying? Like where to start? I meant for someone starting from scratch. Good question. So let's say we take a class. You're supposed to go through the study material. So all the lecture notes. So you go through it. Obviously you need to even memorize those things just to know how to take history and everything. And you were supposed to do role play on those cases. So that's how you should prepare. So every case that we do, you read it by yourself. Even if you need to go through the recording, you do it and you do the role play. Along with that, you also finish your handbook. Handbook, we do most of the cases, but some of the cases which is not that much important, we don't do. So you are supposed to do the handbook by yourself as well. So read the handbook, finish all the cases, but all the important cases that come from handbook will be done by us anyway. But you're supposed to at least read it twice. So do that when you get some time. Course fee. So I hope that you have understood the course fee is $8.99. The timing is same like this. So we take the classes 3 days a week. The classes at the moment is Saturday, Sunday, and Wednesday, 8 to 10:30. Only physical examination, the fees is usually 200 Australian dollar. That's if you are not part of the clinical course, then only fee for physical examination is 200. But the physical examination classes only happens along with the full course. So when we will start physical exam with the full course, then we also allow outside candidates to do just the physical exam. How many mini mock tests included in the course? Usually every 4 to 6 weeks. 6 months preparation full time. For those who have other commitments, I would say that at least take 8 to 9 months. I can't recommend how many hours. It's actually subjective. How much you can do by yourself, it depends. Some people, they just need a little bit of just bird's eye view and they remember everything. Some people need a lot of time to retain things. So this is a very subjective thing, that how much you need to read, how many hours you need to read. It's something you will need to find out. Dr. Cynthia's classes also included in the full course. That's a part of the class that you get. Can we get recording of today's lecture? Yes, the recording will be uploaded in the YouTube and also in your First Aid AMC clinical group. All the recent sample questions will be discussed by Dr. Cynthia. And as you have noticed in the course detail, we have 300. I think right now Dr. Cynthia is on her 90 role play session, and almost everything that you need for your exam, it's in there. So we provide you all the last 3-year recall or role play sessions, and you can go through those sessions along with the new sessions in the new course. So there is nothing you need apart from it. And Dr. AK, you need to practice role play for all the cases in a cluster wise. So when we start our cluster based approach, like the cardiology one, you are supposed to do it as a cluster by cluster, not just general cases. The random cases which Dr. Cynthia does, yes, those cases will be general case that doesn't fulfill any cluster. But some of the random questions she is going to discuss will come under cluster as well. That will be discussed by me. So when you get few classes of us in the free session, you will understand it, how this actually happens. That's right, Dr. Richard. The classes are 8 to 10, not AM, it's PM. We don't take classes in the morning because we have our job in here. So we can only take classes in the evening. So 8 to 10 PM. Classes, especially my class, is always fixed, Saturday and Wednesday. The Sunday class, Dr. Huria, because Dr. Cynthia works in a hospital. In case she gets night shift, then sometimes we need to change the class. But those classes, always we will be able to let you know. Usually 2 weeks before, we always let you know the schedules and what we are going to discuss in the course. So it's never ever a problem or issue. We never cancel the classes immediately before the class. Until it is really a life-threatening or emergency, this never happens. And yes, Dr. Annie, you get all the important things. We always discuss new cases with past cases. So never ever that's a problem. As I said that this course has everything that you need for your exam. There is nothing else actually you need. You don't need any extra notes. You don't need any extra books. You don't need anything. The preparation is with us. Okay? All right. So Dr. Fatima, so when will the admins approve my account? Asking so I can get access note before the course starts. Good question, Dr. Fatima. What we say to the students that because we allow 2 weeks free sessions for you to decide that if you want to continue the classes or not. So within that 2-week session, we don't allow anyone to get into our portal because you get access to everything we give it to you. So if you are sure that you want to join the course, what you need to do that you ask our team. So either you send an email or inbox in my messenger that you want to continue the course and if we can give you the access to the portal. If you want to do that, we will approve your account right away. But if you still want to join the 2 weeks free sessions and want to be sure, then just allow those 2 weeks free sessions to be over, then we will approve your account. And yes, class recordings are always available, usually within 24 hours after the live session. So Dr. Kishani or anyone, if you are not able to join the live session, you can always get into that. 50% of our students do these offline classes. That means they don't come as an online class, they just go through our class recordings. So almost 50% are like that. Yes, Dr. Faria, every time we finish the class, next 24 hours, you get the class recording. The free sessions will start from 3rd of May. Is there a benefit of taking online exam rather than face-to-face? I would say that, as I said initially, if you are very free to talk, you are fluent, then you go for online. Because the only problem in face-to-face is that you have to do physical exam on a person or on your role play. And it might be a little bit tricky if you're not that much confident in face-to-face. But in case of online, you don't need to do a physical exam on a person. You just tell that this is what I'm going to do. So that's why it's easy in that part. Nothing else is easy. Online face-to-face is same. The difference is in the physical exam. So if you are very fluent, you are confident when you are talking, online exam is good in that way because you can just say what you are doing in that patient. But face-to-face is easy to get the registration because getting into the exam registration is also very hard. There is not much online dates available. So that's why I say that face-to-face preparation is better because you can get your exam quickly. But again, if you feel that you are not very confident with doing a physical examination on a person in front of examiner, online is the best way. All right, everyone, I think it should be enough. You will get to ask a lot of other questions throughout the free 2-week session. So just ask me in any time. All right, so we'll be finishing it here tonight. I hope you enjoyed the session. I hope that at least you learned something today and you can start your clinical preparation. Thank you, everyone. Have a good night. And yes, free session is a part of the course. So remember that if you have already joined, free sessions is a part of your course. So please make sure you join these classes. Thank you, everyone. Have a good night. Take care. Bye.